Okay, maybe we can start. So welcome everyone to the final symposia of the Exposome Week. Thank you for being with us for the whole week with exciting presentations. Today we have two interesting presentations, one from Anjuka Pronk from TNO and Steven Ronsmans from KU Leuven. And it's on workplace exposure and disease. And this is something that we are exploring in both the EU projects EPHOR and EXIMIUS, which are funded under the Horizon 2020 program and are part of the European Human Exposome Cluster. So I give the floor to Anjuka Pronk for her presentation. And then the presentation will be followed by Q&A. So you can please add your questions to the chat box and or unmute yourself, raise your hand and unmute yourself if you have questions, and we will moderate that. Thank you.
Thank you, Manosic, and happy to be here. I will be telling something or giving an overview of some work we've done within the EPHOR project, looking at what we do know and don't know about occupational exposures in relation to non-communicable diseases. I'm standing in for my colleague, Ingrid Sivesind Mehlum, who led all this work. It's been a lot of work, and who, due to personal reasons, unfortunately couldn't be here today. So I just want to acknowledge her as the lead of this work. So within the EPHOR project, we aim to apply the exposome concept to working life health in order to provide better insights into working life health relationships and vulnerable life stages and vulnerable subgroups, in order to ultimately lay the groundwork for better funded prevention, so more evidence-based, but also more cost-effective. And we do this within the project by taking a combined approach. So on the one hand, we make use of existing data from existing European cohorts that have occupational exposure data, and we combine that with existing but also newly developed job exposure matrices to be able to study the association between occupational exposure and health. And by doing this in multiple cohorts, increasing the power and also being able to look at different aspects of the working life. On the other hand, the other approach is two case studies, one on respiratory disease and one on shift work, in which we collect new data. And that's been presented on yesterday in the session. Today's presentation is linked to the mega cohort or the cohort approach. So yeah, when we started the project, we had described that we would look at occupational exposures in relation to multiple non-communicable diseases. We know that these occupational diseases are responsible for 5 to 7% of mortality based on well-established dose response relationships. So the ones that have been described with a lot of evidence, also the ones that have the strongest relationships have been used. We know this is probably an underestimates. Partly because only single occupational exposure disease associations have been looked at. Another challenge when looking at prevention of occupational disease is that very little is known about vulnerability. And there are a few upcoming challenges, such as the aging workforce, female participation in the workforce. We don't have specific estimates, so most of the knowledge available that we knew of is for the male workforce. So as a starting point for our own cohort approach within the EPHOR project, we aimed to make an overview of the status of knowledge on occupational exposures in relation to common non-communicable diseases. On one hand, to provide an overview that can be used for prevention, for awareness, for others to use, and on the other hand, to define knowledge gaps to be able to set priorities within our own analysis. So what we've done, we've developed a narrative review. We've divided our group into 6 major working groups for covering the 6 major non-communicable diseases: cancer, cardiovascular, metabolic disease, mental health outcomes, musculoskeletal, neurodegenerative diseases, and respiratory diseases. And each group has done a literature search and has described the states of knowledge for the established, so defining which of the associations they found they saw as established associations, so with sufficient evidence, and which are suspected, so with low or insufficient evidence, and also describing the knowledge gaps. And we did a narrative review and not a systematic review, because the data and literature out there is very diverse. So a systematic review, the state of knowledge is very different for these different NCD groups. So it's very difficult to do a systematic review on all of these together. So the literature we've used as input for cancer, we've decided that all the evidence is very nicely summarized and reviewed by the IARC monographs. So we didn't try to do this again. We've used the IARC monographs to summarize the evidence. For the other non-communicable diseases, we've preferred systematic reviews and meta-analysis, but we've also used narrative reviews, reports, and original studies when certain exposure-response associations were not described in systematic reviews or meta-analysis. And the output of this review was a description of the evidence on the associations between exposures and diseases, for which we described them as consistent if they were indicated. So if an association was indicated as a strong association by state-of-the-art reviews, or it was defined as an IARC by IARC as a group 1 carcinogen, and with limited or inadequate evidence if state-of-the-art reviews indicated weak or insufficient evidence, or if IARC categorized it as a group B, 2B, or if there were only a few original studies on a specific exposure response outcome, or if there was a disagreement between the reviews. And then also each study group described the knowledge gaps. So the results, and these have been published, so all of the coming slides, you can also find the much more detailed information in the publication by Susan Peters, which was published last year. So we found more than 220 occupational exposures linked to 65 non-communicable diseases. And then we looked at them, so each working group looked at them separately. And these graphs give an overview of what they found. And in the paper, you can see information on the specific exposures, for which there's no place here, no space here. For respiratory disease, we see that, well, here you see the number of occupational agents or occupations, industries, or processes that are linked to the specific respiratory disease. So on a scale from 0 to 20, the purple bars are the exposures that are linked with consistent evidence, and orange bars with limited or inadequate evidence. And what you see here is that, well, for some, there are quite a few respiratory diseases that have been linked to occupational exposures. Almost all of the agents were chemical or biological. There were some occupations, industries, or processes, and one psychosocial exposure was linked to chronic rhinosinusitis. I don't know how to pronounce this. I can see that someone can't see the presentation, but I think that's not a common thing, so I'll just continue. And what you can also see is that, so for some of these endpoints, you do see that there's consistent evidence for at least a couple of the exposures, but there are also quite a few exposures still for which the evidence is limited or inadequate. Then if you, this looks a bit strange, but well, So for neurodegenerative disease, if you look at the picture again, orange is limited or inadequate evidence. It's shifted a little bit, but the bars are still okay. So what you see is the orange bars are much taller than the purple bars. So there are only few exposures with consistent evidence and quite a lot of exposures with limited or inadequate evidence linked to neurodegenerative disease. And what also stands out is that the types of exposures are much more diverse than for respiratory disease. So especially for the exposures with limited or inadequate evidence, it goes across the whole spectrum of types of occupational exposures: chemical and biological, physical, biomechanical, psychosocial, and also organizational. So it's a much more diverse type of studies with much more diverse types of exposures. Then for cardiovascular and metabolic disease, again, the picture doesn't look the way it should be, but I think the bars are still correct. They're only sort of overlapping a little bit. What you see is that for many of the cardiovascular metabolic disease, the exposures, the consistent evidence is very limited for most outcomes, except for ischemic heart disease, where there are 3 types of exposure domains that have been consistently linked: chemical and biological, psychosocial, and organizational. But there are many more exposures or exposure types with limited or inadequate evidence. And these go across the whole spectrum of types of exposure. So also physical, biomechanical, and industries, occupations, and processes. And for mental health, the picture is a little bit different. Here you see that actually the exposures with consistent evidence are more common than the exposure with limited or inadequate evidence. And there are quite many exposures linked to mental disorders. Psychosocial and organizational are the most common for both the limited and consistent, and the limited and the consistent groups. And what we also saw was that there was also one chemical or biological agent with consistent exposure, which was linked to suicide. So it is a bit broader than you would expect. Then mental health, also here there's consistent evidence for several outcomes, but well, for most of the exposures, the evidence is still limited. Biomechanical exposures can be expected. Biomechanical exposures and physical exposures are the main types of exposures that have been linked to musculoskeletal disease. But also psychosocial exposures have been consistently linked to non-specific low back pain, but there's also limited evidence for 3 other health endpoints as well. Then cancer, the results are presented in a little bit different way. IARC evaluated about 1,000 agents until now, and occupational agents, there were 47 occupational agents with consistent evidence, so group 1 agents. And on the right-hand side, you see the cancer sites that have been, for which consistent evidence for occupational exposures has been demonstrated. So lung cancer, followed by skin cancer, are the most important ones, or are linked by, that's not really what's shown, are linked to the most diverse types of exposure. So lung cancer is linked to, well, between 15 and 20 different occupational exposures, and skin cancer is linked to a little more than 5 occupational exposures. And then also, if you look at the occupational agents that have been consistently linked to cancer, you see that similar to respiratory exposures, it's mostly chemical and biological agents. And then 19 agents, which are not shown here, have been linked with limited evidence, so group 2B. Then what we did next is that we put all the data together and looked at exposures for which were relevant for more than one disease group. So So most of the time exposures were relevant within a disease group for multiple diseases. But here we looked at if exposures would be relevant for diseases across multiple disease groups. And you see that for this list, which is quite a few exposures, they are linked to more than one disease group, and actually linked to often 2 or 3 disease or even 4 disease groups. So these exposures are quite important to focus preventive measures at. And then this heat map also nicely shows sort of the importance of the different exposures across the different disease groups. So again, you see cancer and respiratory disease are mostly linked to, or only linked to, chemical and biological exposures, with already quite a few known associations. Then for neurodegenerative and cardiovascular, exposures across multiple domains are relevant. And also apart from the ischemic heart disease, you see that a lot of the associations have not yet been confirmed. And then for mental disorders and musculoskeletal disorders, again, you see that more associations have been confirmed. And these are mostly linked to psychosocial organizational exposures. For musculoskeletal, also physical exposures are of importance. So the next step is the main knowledge gaps that we identified, which were overarching knowledge gaps. So mentioned by at least 2 of the working groups. So one thing that was often mentioned was the study design. Reverse causation due to long latency was often expected or mentioned in the discussions of the papers. There were not so many prospective cohorts, so more of these would be needed to get rid of this type of bias. Then also, we looked at different types of studies and if these would be able to be pooled. And very often that's not possible because the studies are very differently set up, different way of exposure assessment, different timing of age groups. So harmonization would be needed if you would want to pool these studies. And that's actually also, we saw that in the literature review, but we also saw that in our own work. We have access to almost 30 cohorts through the project. And we intended to do some pooling, but in the end, and this is partly due to legal reasons, but also due to reasons concerning harmonization, we didn't pool the studies at all. Then with respect to the exposure assessment, for some of the exposures, data were qualitative only, questionnaire, self-recalled. Quantitative data would be much better and would enhance the study quality. And also what we saw is that often only a single exposure or a single exposure domain is studied. So assessment of multiple exposures domains within one study is very, very rare. Then with respect to the case definition, for many of the diseases, harmonization of the endpoint definition would be needed. So now they were quite diverse and self-reported, questionnaire-based, clinical-based, which also makes it difficult to interpret or compare the studies. And for some of the outcomes, for instance, the neurodegenerative, there's a suspicion of underreporting, which may bias the studies that are available as well. Then something we looked at specifically because we're doing an exposome study and we're interested in multiple exposures and vulnerability and critical time windows. So we looked if there were studies that had already looked into that, but actually for all of these, they were very rare or non-existent. So that's another outcome of this study that we didn't. Yeah, we couldn't build on existing studies doing this already. Then I'll step into how we applied this. So one thing we did we created the occupational exposure viewer tool, which was launched last week. You see the website here. It's a tool with which you can explore by occupation, or you can explore by exposure which occupations are exposed and how many people are exposed by country and by year and by gender. And what we did is, for each of the exposures that are in the tool, we added the health effects based on this review. So as you can see in the circle here. And then the main application of this work was the starting point for the cohort analysis within our project, which are still ongoing. So these have been delayed quite seriously, and the project has another 4 months. And actually, all of the working groups are still performing the analysis. So I can't show any results at the moment. So all the working groups looked at the literature independently, then we brought it all together in this narrative review. We talked about common analysis goals, but we saw that the state of the literature is very different for these different endpoints. So actually now all of the working groups have independently formulated research questions and are working on that now. And there are about 19 European cohorts that are under analysis, but spread over the different working groups. So about between 2 and 5 per working group. And then lastly, I wanted to give this overview of the toolbox. So we've developed a toolbox with all kinds of tools for different end users. And linked to this cohort analysis, we've developed a resource for scientists. And you see a screenshot on the right. And it contains an inventory of European cohorts, which has over 135, I think even over 150 individual cohorts that have occupational data, so occupational histories. There is tooling for automated job coding, also for crosswalks that can be downloaded and can be used. There's the EuroGEM, so the set of harmonized job exposure matrices, which has been presented last week. There will be a document on using a GEM for missing lifestyle data, which is often a problem in the registry-based cohorts. And then there are descriptions, but also guidance on how to use different exposome data analysis methods, focusing on 3 aspects. So one is the multiple exposure response, one is exposure time response, and hierarchical analysis. And these can be downloaded from here. And then lastly, a document that's not finished yet, that will finalize at the end of the project, is also lessons learned on making use of multiple occupational cohorts. So sort of the do's and don'ts for future scientists that want to continue this type of work. And with that, I want to acknowledge all the collaborators within EPHOR project, and specifically the authors of the narrative review. It's quite a few of them. And thank you for your attention. I'll stop sharing.
Yeah. Thank you so much, Anuka. Are there any questions for Anuka? Yeah. I see a question. So from Arco, thank you for the great presentation. With regard to chemical compounds causing depressive disorder, please, can you elaborate on how to deal with DSM-5 classification that excludes depressive syndromes caused by toxins?
Oh, I think this question is a bit too detailed. As I said, I was not in the lead of the full overview. I was in some of the working groups, but mental health is not my expertise. Actually, my colleague Karen Oudehengel is, so I can forward this question to her.
Okay. There's one hand from Nadia. Please unmute yourself and you can ask the question.
Hello, thank you very much. It was very interesting. I have just a question. Maybe I didn't fully understand the concern for this reverse causality. While I understand the concept of reverse causality, you were mentioning that this is due to long latency in relation to occupation. So I wanted to understand how could you give me an example of such a reverse causation related to long latency and to occupational exposures?
Yeah. So, for instance, if you study a COPD, for instance, in a case control design, and then you ask for the occupational history, then people with COPD may know about the association and may be more prone to naming more exposures that are relevant. So you would want a prospective design in which you start collecting the data on exposure before the outcome occurs.
Yeah.
But in many studies that's not the case.
Thank you.
Thank you. Any other questions? Anuka, just to bring this, because there are different kind of stakeholders. I mean, how do you see this research kind of driving the bridge between policy or informing policy-driven research that's required at the moment for occupational health? Or what would be your view, or anybody from the audience could also comment on it?
Yeah, so I think I'm not sure I'm totally answering your question, but I think this research can at least show which exposures are relevant and are relevant across different endpoints. So often you look only at one. So it can help prioritizing important exposures for prevention. Yeah, and didn't get the second half of your question. Sorry.
No, but what I meant, yeah, I think it's more like prioritizing these more and driving really policy-based research gaps, filling those in more.
Yeah.
Probably it helps us. Yeah.
Yeah.
Okay, and there's another question. So what was the criteria for selection of main NCD groups? Were gastrointestinal disorders considered for selection given they affect hundreds of millions of people? Yeah.
Actually, they were not. So metabolic disorders were combined with cardiovascular, but gastrointestinal were not prioritized. And I think that may be partly because they may affect hundreds of millions, but I'm not so sure that are they often linked to occupational exposures. So that may be partly because they're not so often linked to occupational exposures, and partly also the creation of the working groups was also a bit pragmatic in that we had specific expert for each working groups. We had an expert there. So, but I can't remember. I would have to look back or talk to Ingrid. I can't remember them being on the list. So would be interesting. They may be often
even
linked to viral or biological exposures as well. Yeah.
And even though, I mean, if I might add, Anuka, here, even though it's not directly addressed through the review, but maybe some aspects of it could be addressed or partially addressed with the shift work study, which is also included. And that's probably one of the factors which does lead to some changes in, so that could be potentially explored there.
Yeah.
Okay. Any more questions or comments? Okay, if there are not any more comments, maybe I can invite the next speaker, who is Stephen Ronsmans, and maybe talk about a bit on the epidemiological data and connecting with clinical observations. So, Stephen, please, the floor is yours.
Yes, thank you, Manosic. Can you see my presentation?
Yes.
Yes, okay. Okay. I will take a bit of a different angle, and as Manosic mentioned in the EXIMIUS project, we are partly studying a group of diseases which are autoimmune diseases. And in this presentation, I would like to show some cases. So I will not take a research angle, actually, and so I will not talk about any research results from the EXIMIUS project, but I will take a clinical angle. Don't worry, I won't give too much clinical details, I think, but it's just to show how these cases look like, and to what kind of exposures are they related. I'm an occupational physician, and the cases I will discuss are all cases from our clinic, actually. The problem of diagnosing occupational diseases in an individual patient is actually not an easy question. And going from research to diagnosing an individual patient is not a trivial question, actually. In some cases, in some diseases, it can be fairly easy to make a link with a certain exposure, especially in case of, for example, accidents. The link between the exposure and the effect is immediate, so it's more plausible to make an association. In some diseases, we can really demonstrate the link. For example, in occupational asthma, we can prove that there is a sensitization or a specific reaction to an exposure. But the more you go lower in this scheme, the more difficult it becomes to diagnose an individual patient. Some diseases, and I will show immediately an example of this group, are specific for a specific exposure. Silicosis is one of those, which is caused by silica exposure, as the name itself says. But once you get here, for example, in the group of COPD related to occupational exposures, it's much more difficult to prove this in an individual patient. And we know from studies that there are some associations between exposures and COPD incidence, but to prove it in an individual patient is almost impossible because the disease presentation is so a-specific. But I'll give an example of this group. This is a relatively young man with silicosis. He had cough, shortness of breath, so that's very aspecific symptoms for lung disease, a bad lung function. And if we took a CT scan of the lungs, you see, especially in the upper fields, there are all white dots, and these are actually silicotic nodules. Often then we try to obtain histology, which can be from the lung, but can also be from the lymph nodes that are in the chest. And here in this case, histology of a lymph node was obtained, which showed actually a silicotic nodule. And the silicotic nodule, so this is part of a silicotic nodule, is the specific lesion of silicosis. So we could prove by these diagnostic tools that this patient has a silicosis. And when you look with a technique called polarized light at the same tissue, you can see the individual silica particles even in the tissue. And just to clarify what this patient had been doing, he had been working in a very small company, only two people, that made artificial stone, as more specifically artificial stone to make kitchen countertops. So this is a nice picture of a countertop, and the stone that you see here looks like a natural stone, but it's actually an artificial stone. And how did they make it? They mixed a resin with several other compounds, including quartz flour. And quartz is crystalline silica, which we know can cause silicosis. They cast this mixture in a mold, and then it became hard as a stone, and then it had to be cut and ground and polished. And it's especially while polishing and grinding that you get a lot of respirable dust in very high concentrations, actually. And when we saw this patient, he said, yeah, actually my only colleague, he also has something to do with his lungs. And eventually we also diagnosed a silicosis in his colleague. And this is a story from Belgium, but actually the same story is repeating all over the world, especially in, let's say, first world countries, US, Australia, Western Europe. And this is because in many of these countries, the existence of silicosis was a bit forgotten. Also, preventive measures had declined in recent decades. And now we have a resurgence, actually, of silicosis cases. And recently in Australia, they have been prohibited the use of these artificial stones. But what does this have to do with autoimmune disease? Well, the name silicosis would suggest that there's only one health effect of silica, which is not the case. And this is a nice review of the literature, which shows that there are many known associations, and some are very well established also with silica exposure. So we have the group of different types of silicosis. And then we have diseases like, for example, also lung cancer and sarcoidosis. Tuberculosis also is linked to silica exposure. It's of course caused by a mycobacteria, but it can be it occurs more in people exposed to silica. And then you have these autoimmune diseases, which have all strange names and are all relatively rare. But there's more and more evidence that many of these autoimmune diseases are related to silica exposure. So I will pick out a few of those, some examples, and I will come back to some epidemiological evidence that exists, some words on mechanisms or hypothesized mechanisms at least. So I'll show a case of systemic sclerosis. What is it exactly? Rheumatoid arthritis, and then I'll also show some cases of sarcoidosis. So this is the first case, and a man who had been doing something that is very similar to the man who had been making kitchen countertops, but he made stairs, and these are nice stairs, but it's also some kind of an artificial stone, more or less the same process, mixing a resin or cement with quartz containing materials and then dry finishing, and by this generating high concentrations of crystalline silica. He had been doing this actually a long time ago, and the rest of his career was an administrative job. And he also at a certain moment developed respiratory symptoms, a lung function that had declined, and then a scanner was done. But the scan didn't show any silicosis. So this man doesn't have a silicosis as would be, as we would have been taught in the textbooks. The radiologists who are specialized in lung diseases, they have this kind of complicated jargon with different kind of patterns. And so this is an NSIP pattern, which is of course not really relevant now, but it's not a silicosis. And then the clinicians have to think, okay, which puzzle, in which part of the puzzle does this fit? What can an FNSIP pattern mean? And together with a lot of other symptoms that this man had, he had tightening of the skin, he had autoantibodies in his blood, he had also megacapillaries, which is a kind of a vasculopathy. He had heart symptoms also. And based on all these symptoms together, especially the autoantibodies, he was diagnosed with the systemic sclerosis. So systemic sclerosis is a systemic disease. Many organs can be involved, and it's characterized by autoimmunity and then fibrosis in different organs, fibrosis in the lungs, fibrosis in the skin, in the esophagus, even in the heart, and also vascular involvement. So that's typical for systemic sclerosis. And then the question is, why would we relate this to silica? Well, actually, there is a lot of evidence. Well, there is consistent evidence, let's call it like that, that there is a link with silica exposure, especially in men. And this is a study that has been done in our hospital. It's a fairly simple study where they acquired occupational histories from all patients in 2 big university hospitals, and more than half of the men had a history of silica exposure, which is not the normal distribution. And actually, this is something that has been suspected for a very, very long time. Even in the beginning of the 20th century, there was this clinician in Edinburgh who noticed that within his group of 9 patients, it's a very rare disease, that 5 of them were stonemasons. So he thought it was very, very strange, but didn't really know what the exact cause then would have been. But then in the 50s, there was a larger study in South Africa in gold miners exposed to respirable crystalline silica that made the first epidemiological link. And actually, almost all the studies that followed were clearly positive for this link. And the acceptance of this link has been a bit patchy. So it's not like silicosis that is recognized as an occupational disease worldwide, but it has been recognized as occupational disease in some countries. And the first was South Africa, because the first study was performed there. And then in Western Europe, there were also some countries that have accepted it. And recently also Belgium has added this to its list of occupational diseases. So specifically silica-induced systemic sclerosis. And there is one interesting study that showed some more data on exposure. So here they tried to find silica in urine and serum also, and compared patients with systemic sclerosis with controls, and they found more silicon, actually, especially in the serum of these patients, which is interesting, but it's not an established biomarker of exposure, but it certainly gives some clues and more ideas for research. And here the group of Michael Pollard, they have this nice review of the hypothesized mechanisms actually. And so the main hypothesis is that probably the silica particles that arrive in the lungs cause some kind of a chronic inflammation that eventually leads to an immune reaction to self-proteins or modified self-proteins. I'll come back to that. And these autoantibodies, as they call them, could cause disease in different organs. And in different autoimmune diseases, the patterns of disease are very different. So systemic sclerosis is here, but there are other ones that might be caused via the same mechanism. And I'll show also an example of rheumatoid arthritis. And so this is a man who had worked in silica mining. So his job was actually getting silica from the underground. and processing the silica. And he had been working in this company as a maintenance technician. Maintenance technicians are people who are in many circumstances the mostly exposed because they come into contact with processes, often processes that are normally enclosed, that they have to do reparations. He had the typical symptoms of rheumatoid arthritis, which is actually joint pains and swelling, so arthritis in different joints. He had a normal lung function, and he had the typical autoantibodies that are related to rheumatoid arthritis also. And so what did they do in the company? Actually, they mined quartz sand, so crystalline silica, but the company sells it in different particle sizes. So there's a process of grinding also this quartz sand. And this is an electron microscopy picture of this ground quartz. And it's very interesting because there's a stream of research from this group, from Pavan and Fubini, who say that actually freshly fractured quartz might be even more toxic than aged quartz particles. So that's interesting because in this case, this was exactly what he was doing, or the company was doing, like grinding quartz particles into finer and then freshly fractured particles. Also in this patient, histology was obtained because he had large lymph nodes. And in this lymph node, we saw a rheumatoid nodule, so which is the typical lesion for rheumatoid arthritis related to exposure or not. But also in this rheumatoid nodule, the individual particles of crystalline silica could be found, which is also an interesting finding. And also for rheumatoid arthritis, actually, the suspicion that this is related, or in part of the patients related to silica, has been there for a very long time. So in the 50s, and these are publications from Belgium, so that's why I show them. There has been a publication in 2 young women with severe rheumatoid arthritis and silicosis also, who had been making silica-based scarring powder. So in that, in the 30s, 40s, 50s, and also later, many of the scarring powders, so it's powder to clean your bathroom and kitchen, were based on silica actually. So the base material was silica with the detergent. So we know from these studies that those that were packing the powders had been exposed to high concentrations of respirable silica. So this is not the industrial jobs we know now, mostly related to crystalline silica. But also now these powders don't include crystalline silica anymore. But at that time it was very typical. Also in miners, the same associations had been shown also in the 50s. And this picture that was shown by a pathologist also in the 50s is very similar to what we saw in our patients. So a typical rheumatoid nodule, as they call it, that contained dust actually. Also for rheumatoid arthritis, there have been many studies. A large meta-analysis showed a clear association, and also many studies afterwards showed clear associations there. And when coming back to these hypothesized mechanisms for rheumatoid arthritis, the hypothesis is that this exposure to silica causes modification actually of proteins in the lung. This modification is called citrullinación, which can generate an autoantibodies against these citrullinated proteins. And this is actually what we find in the serum of these patients. So that was systemic sclerosis, rheumatoid arthritis, and then you might think, is this something more broad? And actually, there are studies that suggest that the link with autoimmune disease might be broader, and I mean systemic autoimmune diseases. The left study was a study in lung transplant patients who had silicosis also. But the strange thing was that they noticed in this group of 40 patients over a 15-year period that 9 out of the 40 had an autoimmune disease. And normally all of these autoimmune diseases are extremely rare. So 9 out of 40 is extremely much for a small group like this. In a more larger and systematic study on the DOC-X cohort in Denmark, they showed the same associations as we knew already, systemic sclerosis, rheumatoid arthritis, but also with 2 other systemic autoimmune diseases. And the nice thing about this cohort, of course, is that it and includes all Danish workers for a 40-year period, actually. So this is very nice evidence, actually, to support this. And then to finalize, I have one other disease, which is actually not considered an autoimmune disease, but it is an immunologically related disease, and it's sarcoidosis. And normally, if you read the textbooks on sarcoidosis, it starts more or less always in the same manner. Sarcoidosis is a disease of unknown etiology, and that is true. But we know some things about sarcoidosis, and we know that it is a disease in which granulomas develop. So it's agglomerates of immune cells in various organs. And it's probably caused by a genetic susceptibility and then an unknown antigen. And from epidemiological studies, it is suspected that there might be a link with metal exposures, especially with beryllium, but maybe also some other metals. Again, silica, the villain of this story, is again there with a lot of studies showing associations between silica exposure and sarcoidosis. But it can also be, in some studies, they show actually a link with organic dust, so more with molds or infectious agents. And this is a patient we had in our clinic, a very young man with a clear medical history, who had been diagnosed with sarcoidosis, and we saw him a few years later, who had been working in a lamp factory with in a workshop with about 30 workers. And he was told, yes, you have this disease which we don't know the origin of, and it's a very rare disease. And this man said, okay, if it's very rare, that's very strange, because I have one colleague with exactly the same disease, and we are only 30 workers. So we saw this colleague, and he had indeed exactly the same disease, and he worked in exactly the same workshop. So what were they doing? They were actually making lamp tubes out of an amorphous silica. So it was not crystalline silica, the base material, called fused silica. It was heated and clipped, and the machines generated high amounts of white clouds of dust. That's what these workers were telling us. Some of the dust was analyzed, and it was indeed mainly amorphous silica with a little bit of crystalline silica. Measurements were done, especially during the cleaning of the machine, which was the most dusty task, which showed respirable dust, which was many times above the limit value for respirable amorphous silica. And also in these patients, sarcoidosis is also a disease for which we often need histology to do the diagnosis. Particles of silica were found in the lungs and the lymph nodes. And some years later, we saw a third person from the same workshop who had been doing exactly the same job as the two first ones. So we suspect, although it is open for discussion, of course, that the disease in these 3 workers is due to this exposure because it's a relatively rare disease, and in this small group it would be strange to have 3 people. They have a relevant exposure to this type of silica. In all 3 of them, we found these particles in lung or lymph node tissue. And also, there has been some improvement after the exposure has stopped. And there are also other studies that have shown a link with dust exposure, and especially the studies on the World Trade Center first responders are very convincing. So there are several large cohorts of people that have been working, so firefighters and other first responders after the collapse of the World Trade Center. They had been exposed to a lot of different types of dust. But in all of these cohorts, they actually show an increased incidence of sarcoidosis. And this is a nice cohort because it is a cohort of firefighters that has been followed since '85 in exactly the same way for many years. And they convincingly demonstrate actually that the incidence peaked right after September 11 and stayed increased in the years after. So for the moment, the main hypothesis is that sarcoidosis might be actually a combination of different diseases or at least different causes. Silica might be one of them. Probably there are also other causes, but that is to be explored. So to conclude, I think one take-home message, and this is of course especially for clinicians interesting, that silicosis is not the only health effect of silica exposure. Although I've shown some examples of silica exposure and these autoimmune diseases, for most of the patients with these autoimmune diseases, we don't know the cause because the majority of them are not exposed to silica, but it is suspected that other exposures might be linked to the induction of their disease. And this is something we are studying in EXIMIUS also. And in general, in clinical medicine, the acceptance of these associations is very slow. As I've been showing with the systemic sclerosis story, the inclusion in occupational disease lists is very patchy all over the world and relatively slow. Okay, I'm open for any questions.
Thank you, Stephen. There are a few questions already in the chat. And if anybody else has questions, please, you can unmute yourself or raise your hand. So the first question is from Esther, evidence on asbestos, and so wants to ask about evidence of asbestos and immune-mediated diseases.
Oh yeah, that's a good question actually. Yeah, there are some studies that look specifically at asbestos and autoimmune diseases, also at asbestos and autoantibodies without having the disease, and they showed some associations. But what the difficulty is in these studies is that many of the workers exposed to asbestos have also been exposed to silica. So then the question is, in these studies, what are we looking at? Are we looking at this effect, an effect of asbestos or an effect of silica? But it is suspected also indeed, but it's less clear actually. Yeah.
Thank you. Then there's another question from Nadia. Why freshly grinded quartz may be more toxic than the aged quartz?
Oh yeah, that's a very good question. And I think I will go back to this slide. Where is it? So there is a lot of research from this group. If you look at Pavan and Fubini, you will find very interesting and complex studies, but they have done experiments and really compare toxicity also in vitro of not fractured and freshly fractured. And so their hypothesis is that on the surface of these freshly fractured particles, there's something changing. And they call it silanol disorganization. So really at the surface of, so you have to imagine this is actually the surface, and the particle is here. And this is the surface, and this is a biological membrane. And here they say this is not fractured, so well organized, or whatever you call it. But when you fracture the surface, these silanol groups get disorganized, and they say that this is exactly what can cause an effect on biological membranes, and they have nicely showed that in vitro studies also, and which is very different than the non-fractured. But if you're interested, these are really the publications to go to, actually. Yeah.
Thank you,
Just a
Stephen.
question on this. Sorry.
Yeah, go ahead, please.
No, because what I had understood is that the fractured, when it was just grinded, it was more toxic than after some time. But no, now you are saying the difference between the sand and the grounded, no?
No, I think we mean the same thing. So this is a particle which is aged, let's say, and comes like this out of the ground without fracturing. And this is after grinding and thus fracturing the smaller particles, and then you get surfaces that are more reactive, let's say. So that's what they demonstrated. Yeah. But of course, also these particles are smaller, so which means that more can reach the alveoli also. So that's another thing. Yeah.
Thank you. Then there's another question on the chat from Ricardo. So it is known or hypothesized why some individuals exposed to quartz develop accelerated silicosis rather than simple form. May this be related to exposure dose or some genetic predisposition?
Yeah, that's a good question. I think for silicosis, as for any disease, there is predisposition, of course, but less than in many of the immunologically mediated disease. So silicosis is really the most important factor is exposure dose, or the cumulative exposure, let's say, and more than genetic predisposition, I think. But why then different forms of silicosis? Indeed, you have the simple ones and the complicated ones. That is much less clear. So yeah, there are large differences in prognosis, and that's not very clear. Why some people develop another subtype of silicosis? Actually, that's less clear, and as probably maybe less to do with exposure. Yeah.
Thank you. Then there's another question in the chat from Akela. How is silica exposure related to tuberculosis? Can you explain?
Oh yeah. The studies on the association between silica exposure and tuberculosis, many of them have been done in South Africa, in gold miners, in a context where there is a higher prevalence of tuberculosis in general. And the hypothesis is that so when respirable silica is inhaled, reaches the alveoli or the deep lungs, it has to be cleared. And the first line of defense is actually the alveolar macrophages. But crystalline silica is actually toxic for these alveolar macrophages. So they try to clear it, but it doesn't always work very well. And the same thing goes for the mycobacteria. So these same macrophages are supposed to be clearing also microbial agents, including mycobacteria. So probably there's some kind of an interaction that the silica exposure prevents macrophages from doing their job in microbacterial clearance. So probably it's something there going on. So it's of course not that silica causes tuberculosis, but it increases the risk of getting clinical tuberculosis actually.
Thank you, Stephen. And there's one question from the online chat. John, please go ahead.
Yeah, thanks so much indeed. Really enjoyed the presentation. If you were just looking at people exposed in the sort of high-income countries, sort of more modern exposure, if you like, in terms of the numbers, how relatively important are the autoimmune diseases caused by exposure compared to the sort of traditional silicosis diseases?
Yeah. Well, yeah, that's a good question. It is let's say in absolute numbers, it is of course a relatively small phenomenon, I think. If you think about, for example, systemic sclerosis, the prevalence in Belgium, for example, we have about 2,000 patients for the whole country. Most of them are women who did not have an exposure to silica. Part of them are men, and then in a subgroup of these men have been exposed. So it's rare diseases, and probably silica is only one of the causes. And in some of these autoimmune diseases, the contribution of silica is maybe established, but small in absolute numbers. So indeed, it's a good question. Also, you could say what we don't know is what is the exposure needed to induce these diseases. For silica, we know very well what is, or we think we know very well the limit values that are protective. But for these diseases, we actually don't know. And actually, from these patients, I have the impression that most of them worked in relatively bad working conditions with exposures far above the normal limit values that would protect them against silicosis. So, yeah. So in absolute numbers, small, yeah.
Thank you. And then there's a question in the chat from Peter, who asks, aside from mineral particles, are there organic compounds, example solvents associated with autoimmune disorders?
Yeah, that's a question that is much less well established, I think. There is literature on some solvents. Trichloroethylene has been associated specifically with systemic sclerosis, for example. Other solvents have been suspected, but it's much less clear actually. The evidence is much less strong. But probably there are other causes, let's say. But so it's an interesting problem to study, I think, and then there's much open still.
Thank you, Stephen. There are, I think, just 2 follow-up comments or questions, rather on tuberculosis again. So a follow-up question from Akila, and then from Shadrick, if I'm not pronouncing it wrong, sorry. How much would be the disease severity if you're thinking about co-exposure, but also the TB risk is lifetime once a person has silicosis. So Mark comments, but if you would like to clarify on that, or either the commenters can,
on the disease severity, there have been some studies that tried to do, for example, silica exposed people with an autoimmune disease have another prognosis than non-silica exposed, and there are some clues that they have a worse prognosis, especially in systemic sclerosis. But it's very little studies actually, so it's not so clear. The TB risk, that's a good question, and I don't know this literature very well, but I think there are studies that show that either, and that's especially in the South African gold miners, many of them go back to their home country after working as a gold miner, and I think they have a higher incidence of tuberculosis also after stopping their job. And it makes sense in some kind of way because the silica particles, they are very biopersistent. So as I showed in many of these biopsies, we find them back. And so they stay partly in the lung. So that means that their effect can be prolonged after the stopping of the exposure. And that's also what we see in silicosis patients, for example, that the progression of the disease can progress, specifically in silicosis, after the exposure has stopped, because the external exposure has stopped, but the internal exposure might not have stopped because part of these particles have been retained in the lungs and the lymph nodes.
Okay, thank you, Stephen. If there are no more questions or comments, I mean, related to both the presentations, thank you everyone for joining. It was really a nice few days of interesting discussions and quite many questions for us as projects to address. Thank you once again for joining. We will shortly share a survey with you, but also the recordings will be made available online in the coming weeks. So you can revisit those presentations and share it with your colleagues. And please do reach out to us if you have more questions at any point in time. Thank you so much for joining.